Okay, our next topic is asthma exacerbation. Now, the most important thing to do with an asthma exacerbation is to recognize the severity of the attack. We want to determine the severity of the attack, and a severe asthma attack is actually defined by diffuse wheezes with a peak expiratory flow of less than 150. Now, what do we want to do when this patient comes in with an exacerbation of asthma? We want to assess certain things. We want to assess their mental status. We want to see if the patient's speaking in full sentences. Is the patient cyanotic? Are they using accessory muscles to breathe? And we want to check their vital signs, of course. And the first step we're going to do once we've confirmed this asthma exacerbation is a beta 2 agonist such as albuterol as well as oxygen. This is the most important thing, and it's the first thing that we're going to do. Second step is inhaled steroids, and the inhaled steroids are given to decrease the inflammation. And we know there's a lot of long-term side effects with inhaled steroids, so we're going to taper them off after 14 days. If this is a life-threatening asthma attack and it's poorly responsive to our albuterol beta-2 agonist, this is known as status asthmaticus, and these patients are going to come in with pulsus paradoxus. The management is a little different. We're going to do intubation, IV corticosteroids, albuterol plus ipratropium. If the patient has shortness of breath, what do we want to do? We want to give IV intravenous methylprednisolone, okay? Because the patient is currently short of breath, and steroids are going to take, oral steroids are going to take 24 to 48 hours before they work, so we want to give IV methylprednisolone to take care of that shortness of breath immediately. And our next step is going to be a chest x-ray, because the chest x-ray is going to look for precipitating causes of the shortness of breath, such as pneumonia. And if the patient's coming in with a shortness of breath and it's actually unclear, this diagnosis is unclear, the asthma diagnosis is unclear, we're going to do PFTs before and after we administer bronchodilators. So when we do our PFTs, if there's an increase in our FEV1, we know the diagnosis is asthma. If there's an increase in FEV1 over 12%, we've made our diagnosis of asthma. But if we do our PFTs and the PFTs are normal, we got to do another test that we've all heard of. It's called the methacholine challenge test. And if the forced expiratory volume at 1 second is decreased based on the methacholine challenge test, we've made our diagnosis of asthma. But if it's normal, the patient's going to be normal. They don't have asthma. And for the chronic treatment of asthma, for children, what are we going to do? We're going to give bronchodilators plus cromolyn. And for adults, we're going to give bronchodilators plus steroids. But what you want to remember for the test is chronic treatment of asthma, leukotriene inhibitors. This is the only time that leukotriene inhibitors come into play, okay? Because we know that oral steroids are actually, they have a very bad long-term sequelae. So patients are tried out on a trial of leukotriene inhibitors before they're put on oral steroids chronically, okay? And this is the only time where leukotriene inhibitors are the answer for your test, because we're going to try them out with leukotriene inhibitors, and then we're going to put them on chronic steroids if need be. And a commonly tested side effect of leukotriene inhibitors on the test is Sturge-Strauss syndrome. And basically on the CCS, what I want you to remember is that if a patient comes in with an asthma exacerbation on CCS, you're going to order an ABG and oxygen at the same time. But remember, we're going to actually order the ABG and O2 prior to the administration of therapy. And just for your own knowledge, the most important parameter of the ABG itself in an asthmatic patient to see if they're doing well or not is the CO2 level, okay? Remember, in asthma, they should be blowing off CO2, right? So if you see a normal level of CO2 in an asthmatic patient, that's a bad prognostic sign, because they should actually have a low level of CO2 because they should be blowing off the CO2. So basically, let's do a quick review. Asthma exacerbation, severe attack, is defined by diffuse wheezes and peak expiratory flow less than 150. What are we going to do first? We're going to do beta 2 agonist plus oxygen. Second, inhaled steroids, which we're going to taper off after 14 days. If it's a life-threatening asthma and it's not responsive to albuterol, we're going to do intubation, IV corticosteroids, albuterol plus ipratropium. This is known as status asthmaticus. The patient has shortness of breath. We're going to do IV methylprednisolone because we want an immediate effect, and the steroids are going to take 24 to 48 hours to work. We're going to do a chest x-ray to look for the precipitating causes such as pneumonia. And if the patient comes in with an acute shortness of breath, but it's an unclear diagnosis of asthma, we're going to do PFTs before and after our inhaled bronchodilators. The PFTs are normal. We'll do a methacholine challenge test. On methacholine challenge test, if the FEV1 is decreased, we've made our diagnosis of asthma. If it's normal, the patient's normal. And on our PFTs, if the PFTs are not normal and there's an increase in FEV1 over 12%, we've also made our diagnosis of asthma. And remember, on the CCS, you want to get an ABG and O2 at the same time prior to the administration of asthma. And that's our asthma exacerbation algorithm. Enjoy.